Dear colleagues, my name is Hanna Balytska, presenting alongside with Dr. Salma, Khalil, consultant anesthetist, and Dr. Kieran Moloney from the Department of Anesthesia at University Hospital Limerick. Today we are sharing a real-world case that underscores how BIS monitoring can serve not just as a depth of anesthesia tool, but as an early warning sign of that knows before the monitor when something goes wrong. We had a patient in her 60s with a background of peripheral artery disease, hypertension, type 2 diabetes. She came in for elective femoral artery reconstruction. We decided to do TIVA with propofol and remifentanil. Neuromuscular blockage was achieved to be a rocuronium. BIS and invasive arterial monitoring were initiated before induction with a clear signal and a baseline BIS of 97. For the first 2 hours, everything ran smoothly. BIS stayed between 32 and 38, and MAP was stable above 65, with low-dose phenylephrine support. But then, approximately 2 hours into the procedure on closing, the BIS dropped suddenly to 10, without any change in anesthesia dosing and with no artifacts were noted on BIS. 15 minutes later, MAP dropped as well and dropped less than 35. Surgeons immediately re-explored the surgical field and found concealed bleeding. After hemostasis and transfusion of 2 units of red blood cells, the patient was stabilized and extubated in theater. Post-op, she had only transient confusion with no lasting cognitive deficit, and BIS returned to normal after the transfusion as well. This case highlights the important points. BIS isn't only about depth of anesthesia, it can be a real-time reflection of cerebral perfusion. In this case, the BIS drop gave us almost 15 minutes lead time before hemodynamic signs appeared. That's a window of opportunities that could be life-saving in other contexts, especially in vascular surgery, where bleeding may be concealed and sudden. We believe this case reinforces BIS as a critical tool in intraoperative neuromonitoring, not just for guiding anesthesia, but for alerting us to physiological compromise before conventional monitors do. So, what is the takeaway? If BIS drops unexpectedly and your anesthetic dosing hasn't changed, investigate. Think perfusion. Trust your monitor, yes, but trust your clinical instincts even more. Thank you.